Loveridge with the North Central Regional Center for Rural Development and project director for the Community Assessment and Education to Promote Behavioral Health Planning and Evaluation Project, which is funded by the Substance Abuse and Mental Health Services Administration in collaboration with the United States Department of Agriculture. And we're pleased to have on the line today Sandro Galea, who's going to talk about some of the work he's doing here with understanding the health of local populations. And if you've got a question for Sandro, just put it in the chat box there on the left-hand side. I'll monitor that and break in occasionally to remind Sandro that the chat is there. So with that, I'll turn it over to Dr. Galea.
Good, I guess it's morning where I am. I presume it's morning or afternoon where you all are. Thank you, Scott and Rosa, for inviting me. So I was asked to speak a little bit about this concept of diagnosing communities and to talk about some of the different modalities of data we have been using to understand the health of communities. So plunging in, I'll put my biases on the table. I comment this very much from an urban community perspective. I am faculty at Columbia University in New York City. And I am putting this on the table not simply to acknowledge my bias, but also to put it on the table for everybody's consideration that when we talk about communities, we not infrequently have this hyper-local perspective. This is the quintessential New Yorker cartoon, suggesting that the rest of the world that really is about as big as between two avenues in New York City. But also, to put another concept on the table for everybody's consideration, is the notion that has gained currency in the past few years, is that there are aspects of communities that influence the health and well-being of community residents that are over and above the characteristics of the individuals in those communities. This is from a New York Times Magazine article about 10 years ago, saying that stress is the killer haunting America's cities. So with the notions that when we think about communities, we are thinking about localities that we want to understand, and with the notions that these communities have characteristics that transcend the individuals within them. Now let's talk a little bit about communities, how they're changing over time, and how we can understand. Urbanization has been this enormous demographic shift. We are now living in communities in a very different way than our grandparents ever did or ever imagined. And just to make this point, drive this point home quickly, this is a map of the world. The countries colored in dark blue are countries where at least half the population lives in urban areas. And just to run it through quickly, that's in 1960, 70, 2000, 2010, 2020, 2030. There's a bit of a delay between my slide pressing and the slides happening. I apologize, let me just go back. And that's all the way to 2050. So that really gives you a sense of how urbanization is sweeping the world. And my favorite cartoon on this is this explorer who says, some days all this would be infrastructure, which is very much the way it feels sometimes. Now, this is not all happening uniformly around the world, and I thought it's worth, although we're speaking here principally in a domestic context, to reflect on the fact that urbanization is happening principally in lower and middle income countries. And what you see here in this figure is that the greater pace of urbanization is in the diamonds and in the circles which are in low income countries. And making that point more clearly, although when one thinks of casually of Africa, one thinks of it as typically rural, but in fact the urban population in Africa is larger than it is in North America today. And most of the world's cities are in low and middle income countries, which is unprecedented historically. So I thought in any discussion of communities, diagnosing communities, understanding communities in 2014, one needs to reflect on this tremendous demographic shift that is part of urbanization worldwide. Now, having said that, what is a community? One could spend easily the whole seminar on what is a community. So I just want to show you a couple of snapshots to provoke everybody's thinking. This is Manhattan, where I live and work, and what you have here is multiple communities as defined by the city for administrative purposes. And you'd say, well, it's Manhattan, it's one of the oldest, best characterized cities in the world, but this now is a slide from an informal settlement called Rio das Pedras in Brazil, where we do some work. And what you see, the colorful lines, are lines demarcating communities within this informal urban area, within this slum, showing that even in informal settlements, there's this impulse to try to define communities within urban areas as well as there is within rural areas. And just to go back to New York City for a second, this is New York City, the area in blue, you see the 5 boroughs of New York City, but very quickly one realizes that is that New York, or is that New York, or is that New York? And these are obviously areas of substantial urban sprawl. And on the counter of this, I want to show this particular map, which one would argue is a city in all intents, and this in fact is in Saskatchewan, Canada, which is Saskatoon, a city of really only about a few tens of thousands of people, but it becomes very much a urban community in the context that there are no other cities around it. So I think when one thinks about, well, what is a community, how we define communities, one needs to think not only of the properties of the community itself, as well as the properties of the area around it. And in fact, the US Census defines an urban area as a place with reference to the adjacent densely settled territory. And there is a definition which you can all read here about the density of the surrounding territory that helps the US Census define whether a community is considered urban or not. So, having said that, having given this frame of this shift in global demographics, having given this frame that particularly in ever-growing density of communities, it becomes a little bit harder to define communities, but within that there is always this effort, it's almost this human effort, this tendency to try to figure out communities within these densely populated areas. How then do we map intra-community characteristics? I suppose my going in comment here is that there's no such thing as a monolithic city. There's no such thing as a densely populated community that's all the same, but instead there are characteristics of communities. There are intra-urban characteristics, intra-community characteristics. I want to show you some examples of that from some work that we had done in Detroit. There's a picture of Detroit today, and Detroit's been very much in the news, and this is a picture which I took, which you can see where it comes from. And what you see here is the forefront, these fairly abandoned buildings, and in the background, of course, the gleaming towers of GM, which I think represents some of the contrasts in Detroit today. We conducted a study called Detroit Neighborhood Health Study, where what we did is we wanted to characterize these intra-urban communities in Detroit, these neighborhoods in Detroit. We use these communities that are listed all here, that are defined by the city of Detroit. We conducted systematic neighborhood evaluations. We had teams that were all wearing blue t-shirts, as you saw, as you can see in this picture. And what we had is a list of 18 characteristics that were indexed with photographs as follows. So this was, for example, a yes-no response about whether or not the buildings needed major repairs, with a picture of a no response on the left. The building did not need repairs, and a building that needed repairs is a yes on the right. Then what we did, we selected block groups at random using different sampling strategies. And within each of these block groups, we had a very systematic assessment where we had our reviewers going around each of the street segments, evaluating each of the buildings. Now, just to show you a couple of things that we found, so focusing on the poor external building conditions, we're able to create maps of Detroit that look like this, where the dark areas illustrate worse neighborhood building conditions as then characterized by the systematic mapping exercise. Now, one of the reasons I'm showing this is because of, I think sometimes we get ourselves into this cognitive error of thinking, well, we all know the bad areas in cities, and bad areas are just bad areas and they're bad on multiple dimensions. But this is external building conditions, so just look carefully at where the dark areas are on this map. Now, let me show you something else. This is graffiti. This is presence of non-art graffiti. We're very careful that, to distinguish the two. And here are the areas where there was more graffiti, which, as you actually see, really has fairly little overlap with areas of poor external building conditions. And I'm going to come back to these slides afterwards to discuss how these characteristics of communities may influence the health of urban residents. But I think this exercise simply illustrates the point that one can characterize cities on multiple dimensions, and these multiple dimensions may matter differently for health. Coming back to New York City, this is a map of New York City, just looking at household income in New York City. The darker the color, the worse it is. You can see lower income in the South Bronx, Upper Manhattan, Central Brooklyn in New York City. And I just want to highlight how much community heterogeneity there can be here. So I just want to focus on only two neighborhoods, which is the Upper West Side, which is left of Central Park, as well as the South Bronx. And those two neighborhoods are tremendously different, even though they're only about 3 miles apart. Upper West Side, income about 4 times what it is South Bronx, percent below poverty level about 1/4 what it is in South Bronx, same as unemployment, high school education, percent of people less than high school education about 4 times in South Bronx what it is in the Upper West Side. Assaults are also substantially different. And these neighborhoods also look different. It's just pictures of South Bronx and Upper West Side. But the point here is that we can characterize intra-urban characteristics systematically, and that careful characterization can be some of the essential first steps to thinking about how intra-urban characteristics, how features of local communities are shaping the health of local residents. Now, moving on to health. So why, I think it's all fine and good to characterize communities, but why do we think communities affect health? I sit in the School of Public Health. My job is to try to understand health. So why would we think that these communities, doesn't matter what demographic trends are, may influence health? And I think there are 3 reasons on which to base a thinking that communities may affect health: intuition, theory, and evidence. Well, being in science, I frequently think that we underestimate the role that intuition plays, but intuition ultimately guides all our best hypotheses and our best insights. And I think intuitively we understand that features of our communities affect our health. These are pictures from around New York City showing features of good environments, features of bad environments. And I think there is an intuitive sense that these environments somehow influence what we feel, how we behave, what we think, the water we drink, the food we eat. These are all aspects that shape our health, our physical health and our mental health. These are pictures from informal settlements around the world, again giving one the intuitive sense that surely these living conditions matter to our health. So that's intuition. There is ample theory that explains, or at least attempts to outline, how communities influence health. This is from a paper that we did a few years ago, articulating that major global and national trends, things like immigration, suburbanization, influence municipal level factors, government, local policies, local markets, civil society, which in turn influence urban living conditions, demographics, physical environment, social environment, health and social services, all of which influences health. We, perhaps ambitiously here, placed public health intervention and research right in the middle, saying that intentional public health activities play a core role in shaping how major global and national trends can influence municipal level determinants and can influence urban living conditions. One can read theoretical constructs like social disorganization, social comparison, social learning, that explain how it is that features of communities translate into the health of the community residents, and I'll let you look those up yourself. But I just want to show you one last thing on theory. This is a bit of a complicated plot, but all I want you to look at here is that you have on the x-axis multiple different pathologies. You have cardiovascular disease, malignant neoplasm, accidents, chronic lower respiratory disease, etc., all the way to HIV on the right and diabetes on the right. And on the y-axis, you have the range of mortality in multiple communities around the United States. And what you see here is that the conditions on the right have a greater range than the conditions on the left. And what this reflects is that community characteristics are more likely to shape health in particular, or along particular axes than they are to shape other forms of health. And I think this reflects this concept that we have used, that certain health characteristics are more sensitive to local social and economic conditions. And as we think about how communities shape health, we should think about which health characteristics are more amenable to community level influence. And I think it's important for anybody whose job it is to try to understand not just communities, but how communities may shape health, because it is not correct to say, nor meaningful to say, nor fruitful, I think, that community characteristics shape all health. I think some aspects are shaped, but other aspects perhaps are immutable to local social and economic conditions, and they're perhaps more genetic or driven by under the skin factors. So that's theory. Now moving on to the evidence. You know, there is a long tradition of evidence thinking about how community characteristics may shape health. Some of the earlier work on this is a fairly classic work from the 1930s by Robert Ferris and Warren Dunham, which was done in Chicago. There's a book called Mental Disorders in Urban Areas, and what you see on the left is a graphical map of Chicago that they drew, where they were outlining that in different areas where there are zones which they described as zones of transition, working zones, residential zones, commuter zones, they were finding different pathologies. In particular, they were interested in mental disorders. Applying more modern methods, but to really the same thinking that Ferris and Dunham were pioneering, there has been an explosion of work like this in the past 10 years. This is, if you just look up number of studies that are concerned with urban health in particular, you find a tremendous increase in the past 10 years. Now, let me go back to Detroit and some of the work that we did there. It's a map of post-traumatic stress disorder in Detroit, and the darker the color means there's more PTSD. And of course, we did this through a systematic assessment of residents, surveying of residents, and then we're able to map the density of pathology, PTSD, as well as, in the next slide, depression. Now, what is of interest, of course, is can we map some of those neighborhood conditions, some of those community characteristics that I showed you earlier, onto the likelihood of having PTSD or having depression or having other disorders. So this next slide does just that. So the way to read this is you have PTSD, depression, and anxiety disorder. There are two lines for each. You can just focus on the multivariate, which means these are adjusted models. Now what you see here is that you have a greater risk of having PTSD and depression, not so with anxiety, with adverse building conditions, which is on the left axis. If you are living in a neighborhood, in a part of the community which has poor building condition, you're about 40% more likely to have PTSD as well as depression. And then the next slide shows the same thing for graffiti. You're living in a neighborhood with graffiti, you're more likely to have PTSD as well as you're more likely to have depression. Now you might say, okay, well, this is really getting at this notion of things are just bad in particular areas, and maybe it's just a general badness, and understanding community characteristics does not help us with specificity. So one can check that by looking at something more broad. For example, let's look at median household income. So this is now mapping the neighborhoods of Detroit and looking at their household income, the darker being worse. This looks like what I showed you with New York. And one can look at whether or not there's a relationship between household income and PTSD, depression, and anxiety. And what you find is actually no relationship whatsoever, because you can see that the confidence bars cross 1, which is the null, which means that at the crude level, there is no association between neighborhoods as characterized just by income and this particular set of pathologies. That doesn't mean anything about other pathologies, but there were specific associations between other specific characteristics of neighborhoods. In this case, it was built environment and graffiti, and these adverse mental health consequences. So this really gets at the core premise of the seminar, which is this notion that we can diagnose communities. I think we can diagnose communities both by adopting the term, obviously, that comes from curative medicine, but taking our an approach that allows us to characterize the health of communities and trying to characterize the characteristics of communities that are most linked to those pathologies, obviously with an intent to do something about them to improve the health of those populations. Now let me move on to some good news. I think one of the challenges in doing a talk like this and having someone like me who is a public health person speaking about communities and how characteristics of communities can shape the health of populations is that one gives the impression that communities are bad for your health. And I want to make sure that I dispel any such impression. This is from the New York Post, which is my favorite local newspaper. Long live New Yorkers, life expectancy here tops the countries. But I'm using this really to show that I'm not speaking about communities being bad for people's health. I'm actually talking about communities influencing health positively and negatively. And in the aggregate, I think communities have tremendous potential to influence health positively. In the 90s, there were papers like this written about the urban health penalty. And then in the past few years, we've now written papers towards urban health advantage. And I actually think that there is more and more evidence that densely populated communities can confer a health advantage on their residents. And it is up to us who are interested in communities, who are interested in communities, urban or non-urban, to figure out what the characteristics of communities are that influence health so that we can improve those characteristics. So then let me move to wrapping up and trying to centralize the notion of context with a formalism that comes very much from the world of public health. And what I'm going to try to do in my concluding comments is to make an argument as to why it is that communities matter, why it is that understanding the characteristics of communities matter, and why it is that those characteristics are something that we should be focusing on with an aim to improving them. This is how to think of populations, and what I do as an epidemiologist, one tends to think of populations quite a bit, and this is just a generic population. And what we can say is that some members of a population are exposed to something. So in the context of communities, as per this presentation, one can say you're exposed to poor urban physical environment, or to urban graffiti, or to poverty, or whatever community characteristic you're talking about. The challenge and the underpinning to all the urban health agenda and community health agenda, as far as I'm concerned, is the next slide, which says that if we take people who are exposed and unexposed and now look at who has disease, and that's the red axis on people in the population, what you see is that not everyone who is exposed, meaning not all the green people, have disease. Similarly, not everyone who is unexposed does not have disease, meaning that there are some blue people with excess and some blue people without excess. Understanding why it is that some people who are exposed don't have disease, while some people who are unexposed do have disease, is essentially the reason why epidemiologists exist. But for the purposes of this presentation, I want to draw your attention to the implications of this reality. This is just how the world works. So let us take this understanding of the world and now map it in a slightly different way. This comes from Jeffrey Rose, some of the canonical thinking in population health, and on the x-axis you have any risk factor. You can take any risk factor you want. You can say poor built environment. You can also take cholesterol. You can also take blood sugar. On the y-axis, you have prevalence. In almost all risk factors in the world, most of us are somewhere in the middle. Then there are some people who are on the extreme on the far right, some people who are on the extreme on the far left. Now, there is one approach, which is an approach that says we should be improving health with a particular focus on individuals who are in particularly high-risk environments. So that approach says we will focus on some threshold of risk, and let's say the threshold of risk is defined here, and we will work to fix the people who are on the right of the threshold of risk, which would mean that would remove the risk of those people there. That strategy, which I can call a high-risk strategy or a medical strategy, it really is the basis of our entire biomedical thinking, does this. What we are doing is we are focusing only on the green people, and we are acting only on them. So if we could improve health in the green people, we'd be improving health in this group. The problem with that approach is that we miss everybody else. We miss all the blue people who also had disease. I think an alternate, more community-centric approach could be the following. We take this understanding what the risk factor is, and if we try to improve the entire population, we shift the risk factor distribution. And now what you see is that the people to the right of the high risk line are also gone. They are no longer where they were, you've now shifted everybody. This notion of shifting the curve is not just a fanciful academic notion. It actually can be done. This slide is from such an exercise, which actually was shifting the curve of cholesterol in a community in Northern Europe, where what you see is you have on the left was the first set of panels, on the right is when they did succeed in shifting the curve by changing community characteristics. So a population health strategy or a community health strategy would recognize that this is what the population looks like, and what we're trying to do is improve overall conditions to shift the curve for everybody, so that we ultimately end up with fewer people exposed and fewer people with disease. Now, one of the worries I always have in presenting something like this to this audience is that there is the inevitable worry about preaching to the converted, and one might leave a webinar like this with a sense of, well, not only do we know that, but we're all doing it. Well, I would actually like to draw our attention to the fact that we're not necessarily doing that. And if anybody has an idle moment, not while I'm talking, but later, browse Amazon and look for books about health and how to improve health. And what you'll find is books like this. This is just a fairly idiosyncratic sample I took while I was preparing for this talk. That essentially the entire public literature on health is about individual improvement of health, not really about group improvement. And of course, the national discourse on health promotion is very much galvanized by a fascination with the individual, with the genetic basis of disease and health, and with how we can improve our genetic makeup and our biological makeup to improve our health. Now, perhaps one might say that, well, there's nothing wrong with that if that works, but there's much to believe that it doesn't work, and as exemplified perhaps best by the obesity epidemic that everybody here is aware of and we all talk about endlessly these days. It is clear that our communities bear a health burden that is, in some respects, unnecessary, and that through a community approach, improving the overall health of communities, shifting the curve, I think we can achieve greater gains than we do in some respects with our dominant approach. I hope that this has given you a sense of how at least I think about communities, how one can think about diagnosing communities and understanding the community characteristics that can influence particular health indicators, all to the end of improving health in our communities. I will stop there, and I would be delighted to take questions, and this is my contact information if people will want to ask me things afterwards.
Well, thanks a lot. That was a great overview of some of the issues and some of the rationale for working at the community level. You had the one graph where they actually were able to shift the curve. I'm wondering if you could maybe talk a little bit about, what are some things that could be done at the community level to shift the curve on cholesterol, obesity, PTSD, HIV/AIDS, those kinds of things. What community level interventions could work to shift the curve to the left?
Well, I think it's a great question. Sort of in some respects, the natural question from what I said, and I think there are many answers because you listed multiple pathologies. I'll start with obesity. I actually think that structural community level interventions that change the food availability, type of food that's available, as well as exercise opportunities that are available, are the obvious community level interventions that aim to improve things like obesity. Things like HIV, the community level changes could be changing community risk environments, availability of resources that mitigate the potential spread of infection rather than facilitate the spread of infection, meaning making I guess the expression that I use is condoms available in every goldfish bowl throughout the community, rather than creating unsafe, unmonitored spaces which encourage risk behavior. Things like you mentioned cholesterol follows in some respects with obesity. If you want to deal with issues of mental health, things like PTSD, community level approaches would fundamentally be both reducing the risk of trauma as well as community level approaches to mitigate the potential risk of trauma through making sure that those who do experience trauma have the social networks and resources to help cope with that traumatic event experience. So I tend to think that there exists a whole range of creative community level approaches that can be adopted, and that this very much depends on the local community will and range of possibilities. I suppose my one provocative thought that I have that I float out when people say to me, what can we do in our community to improve the risk of obesity, is I say, well, why doesn't the community make escalators illegal? Which, as soon as I say that, everybody pauses and says it's a radical idea. But if you think about it, you still have elevators. Elevators obviously are help people with disabilities and can help us to get to higher floors. But if you make escalators illegal, it just means that all of us, the entire community, has to walk up a couple more floors more than we normally would. And that is the quintessential exercise that shifts the risk environment, so that we are all a little bit healthier and the entire community is a little bit healthier.
Well, excellent. You gave an example. I wish Chris Seeger were on today, because he's definitely promoting those kinds of thinkings too. In terms of community walkability and access to exercise facilities as a way to deal with a lot of these issues that may not be simply affecting obesity, but it could also. It seems like there's some evidence that it's related to depression and other types of mental illness. So I'm sure he'd be happy to hear you talking about the escalators. Are folks on the line ready to put some chat into the chat box there? Not seeing anybody typing, but what about
I will take that as a sign of the great clarity of my presentation.
I think it was clear. On Detroit, though, when you've got such widespread poverty, and I had a colleague that found that one quarter of the houses sold for less than $1 one year, so they don't have a lot of resources to address some of the issues. What are some things that you would advise the city of Detroit, or the person who's now the emergency manager of Detroit, as lower cost things that could be done in an environment where there really aren't a lot of city resources and capacity?
Yeah, I think it's a very good question, and I think my answer would depend on the granular realities of a particular city and or urban or community and what it needs. The more I think about this area, the more I read about this area, the more research I do in the area, I have come to feel that the most effective interventions are ones that are not necessarily resource intensive, that they are structural changes that ultimately shift regulation in a pro-health way. I think a shift in all our minds needs to be that health is promoted not just through health policy, health is promoted through non-health policy. And so, for example, I think promoting health in Detroit, just focusing on food for a second, I think some of the the structural interventions that have been done in other places, like banning unnecessary food additives that are calorie rich and nutrient poor, could have a very good effect. I think it requires municipal will to prioritize the health of residents as something that influences policy across multiple dimensions of municipal life. And why would municipalities do that? Why should municipalities care about health? Well, I think separate and apart from the inherent value and merit in caring about health, I think there are plenty of arguments to be made that a healthier community is a much more productive community, a community that's much more attractive to businesses, and a community that is, at the end of the day, if you want to be fairly craven about it, is going to return much more tax revenue to the municipality. Now I see a question from Sonia Kukal. Can I answer that? So how is the information collected on the building structures being used to improve community health? Well, I think the information collected on building structures really aims to identify the characteristics of communities that are having adverse health consequences. And I think there are two approaches that one can take with that. One of them is to use that as a way of guiding what community interventions might be, and saying that these are interventions, these are areas that could benefit from municipal level intervention. And secondly, they also highlight some of those heat maps that I showed you, highlight areas that may be at particular risk of particular health outcomes in the context of limited resources. It helps, I think, planners target where they dedicate those resources. For example, in New York City, just shifting from Detroit to New York, one of the things that New York City did about 10 years ago, to great success as far as I'm concerned, is introduce local public health offices. They introduced 3 district health offices, one in the South Bronx and one in Brooklyn, I forget where the third one is, in areas of high need. I see there's another question by Courtney Cuthbertson. Says Detroit's interesting. So Detroit's an interesting example. There's a new program where cities auctioning abandoned homes for as little as $1,000. How do you think this program might influence problems of PTSD and depression in those communities? Certainly our data suggests that efforts to improve the physical infrastructure will, at the end of the day, improve the health of those populations. I don't know enough about the Building Detroit program to where people buy abandoned homes, but the notion of replacing buildings with poor infrastructure with houses that are up to code, I think, is an immensely positive idea. And insofar as a program like that could achieve that, I think it would be a program that would be a fine example of what I said earlier, of a non-health policy that can have real health implications. And I don't know the extent to which health was guiding some of that thinking, but I hope it was. I see a couple people typing, so maybe I'll wait for that to come through.
I suspect that it was not. I think they're just wanting to get non-tax-paying homes onto the tax rolls again. There are some interesting qualifications to the program. They're not making, if people are delinquent on current properties, or if they've had code violations in the past, they're not eligible. So I think they're basically trying to encourage new residents who have a little more capacity to maintain homes to move in.
I think hearing that, I think that this goes a little bit to the point I was making earlier, that I think the manipulation of non-health policies to the ends of improving health represents win-wins. I suppose I'm a pragmatist at heart, and I feel like even if health is not a particular value that has that's infusing the policy waters and that's informing what is being done, if we are having policy implementation that is improving health, then so much the better. Doesn't matter what the motivation was.
Well, I think there probably are, successful. It would help with, reducing stress of the people that are in that neighborhood, kind of wondering what's happening to that abandoned house that's on the block, and starting to look shabby, and it would create a kind of stress that could create other sorts of health conditions. So I think they're probably cognizant of that at some level in the city, but it's probably not the major factor that's driving them to implement that policy. And I'm not seeing any other people typing actively, so I think we may have come to the end of our questions. It's very interesting talk. I do appreciate you taking the time to do it. Oh, it looks like some of you might be adding something here real quick. Very interesting, lots of things to think about, again, shifting that distribution. So, thanks very much. If you want to plug into this archive version of this, it should be posted on our project website at healthbench.info today. So if you want to share this with a friend, that's where you can find it.
Thank you for inviting me. I enjoyed it.
Great.